Hello, everyone, and welcome to the webinar on one of the latest progressive trends in the treatment of erectile dysfunction, which is venous sclerotherapy. I'll share with you that I did not know much about this until very recently, and I appreciate Dr. Pittman for the work he's done in this area. I'm Elliot Justin, MD. I'm the inventor of the tech ring, the world's first monitor of the health of the penis, and our goal at FirmTech is better sexual health and longer lives of lovemaking for everyone through technology and data. I want to introduce Dr. Pittman. Hey, Chris, why don't you describe briefly uh, your background, what your mission is?
I'm not known to be short-winded, Elliot, but I'll try. My background, I'm an interventional radiologist. We're image-guided surgeons. We're essentially cardiologists outside the heart. So I've done minimally invasive interventions in every organ in the body. But about 15 years ago, we set out to be among the best in the world at superficial venous disease, and I'm candidly going to say it's far outstripped my wildest dreams. So we are award-winning, world-renowned Center for Venous Care Education and Research, and that's who we are. We're Vein 911 Vein Treatment Centers. We're based in Tampa, Florida. Our sister company, Health Performance Specialists, is the largest network of vein practices in the United States. And I was minding my own business a few years ago, and I got into erectile dysfunction, not by design, but I'll cut myself off until you ask me about that.
Sure. Okay. Well, and by the way, thanks for promoting Mel's Hot Dogs. I've not been there, but
Yes.
not, I kind of get that hot dog penis thing. We'll get into that more, in just a moment.
Well,
Let's first talk about the definition of erectile dysfunction. And by the way, as I showed you previously, Chris, I think this definition is seriously flawed. One, the International Society of Sexual Medicine defines erectile dysfunction as the inability or difficulty in achieving erection. Two, the difficulty in maintaining erection. I feel that these are two totally different groups of men in terms of what their primary medical problem is, and should not be grouped together for purposes of research. And it's led to a lot of mistakes in the research about erectile dysfunction. So here at FirmTech, we have documented close to over 100, now over 160,000 erections on close to 3,000 men. Slide, Riley. And this is what the data shows, which is surprising. Riley, slide. So at the top right there, we see the current understanding about erectile dysfunction, which groups these two types of men together: men who struggle to attain erection, or men who get an erection and then lose it. The incidence of erectile dysfunction goes up about 10% per decade after age 40. I'm 72. By my age, it's about 70%, and this is a disastrous problem for many people. What the data shows, though, when we have the largest data set of men's sexual health, is that surprisingly, men are staying just firm, most men, as they age. So if you look at these graphs, you see that the firmest sex erections are only tapering a little bit by age 70. The first nocturnal erections, pretty much the same thing. And the average number of nocturnal erections barely goes down at all. So why are more men reporting erectile dysfunction, but they're staying hard? Well, the doctors have been thinking that the predominant problem, this is true for about 12, 13% of men, is on the arterial side of the circulation. It's not getting enough blood in because they have heart problems like angina, congestive heart failure, heart attacks, or they have narrowing of their arteries, the pipes that go from the heart to the penis, due largely to diabetes or hypertension or atherosclerosis. So if men are reporting more erectile dysfunction, but the problem for the vast majority of men is not on the arterial side, it must be on the venous side. So every man, as they get older, suffers from venous fading erections of aging, and these are due to blood leaving the penis faster, or what we doctors call venous leak. And I, feel the data point to the fact this has been overlooked, and it's why Dr. Pittman's research and work is so important. So, in the office right now, neurology practices, the only way they have of diagnosing venous leak is ultrasound. And there are lots of problems with this. And Dr. Pittman, what you have a lot more experience with reviewing the work of ultrasound by urologists or by radiologists. What are the problems that you've been seeing with the use of ultrasound in the office? He's not, you're muted. He's muted.
Can you hear me okay?
Yeah, you were muted. Go ahead.
Yep. Well, what have I seen? And I'm speaking as a vascular radiologist. Obviously, there's a test called a penile duplex ultrasound where you can evaluate the health of the penile arteries and the health of the exit veins of the dorsal vein. And that test has been around for many decades. And this is a much longer discussion, but I realized quite early that this test has not really been rigorously uh, tested or improved over the years. And I can't help but bring a lot of healthcare policy into everything I'm going to be talking about today. But basically, a urologist can't do anything with this information, Elliot. So I don't think this test is a great one. Again, this is a much longer conversation, but it's going to show whether you have arterial insufficiency, not enough blood flow to the penis. It's going to show you whether you have venous insufficiency, too much outflow of blood from the penis. But if you have practitioners using a diagnostic test that they can't really do much with until you've taken the pills, maybe done intracavernosal injections. And then the third option, of course, is implant. You're not going to need to repeat that test and really rigorously evaluate it. Does that make sense? They're just making a diagnosis. Hey, you got bad arteries, bad veins. There's nothing really we can help you with here except for pills, maybe ICI injections, and then call me when you need an implant. Okay, that's from the urologist perspective. So we do our own penile duplex. I think we do them out to 30 minutes. We're seeing some interesting things. I have reason to believe that antihypertensives, it's common sense, is going to contribute in some ways to erectile dysfunction. I don't want anybody who's listening to me to get off of their antihypertensive medications, but there's still a lot to be learned about this test. And patients put a lot of focus on tests, right? I'm both a surgeon and a radiologist, and it's normal. Hey, doc, get me an MRI, give me a CAT scan. But patients need to understand that's history is 80% of the diagnosis now and forever. And forgive me, I lecture, at the university, and I just go on and on. But I don't think it's a perfect test. I'm not withholding our treatment based on that test. I think too many people, it's like, oh, well, I don't see any venous insufficiency. So you don't have a venous leak and have a nice life and take your pills and do your injections.
Yeah, Chris, if I could just interrupt, I think the problem is one, there's significant inter-user variability. So the results on the part of
Yes,
one person might
yes,
not be reproduced by another. Even within practices, I have doctors saying, "Hey, I
correct,
only trust my own ultrasounds. I don't trust the other people's ultrasounds," which suggests to me that
correct.
it's somewhat of an untrustworthy study. And also, it doesn't really reproduce what's going on under real life circumstances. I mean, it's done in the office, um, and I got to make one of the comments too about there are other antihypertensive alternatives too. So yeah, don't get off your
We,
antihypertensive medications, but if you're taking a beta blocker, or you might want to consider changing to a calcium channel blocker. And there's nothing wrong, I think, today with people going to their doctors and saying, "Why, I think this medication might be affecting my sexual health." Because Chris, in the interest of time, so
yeah.
let me just go on. Let's talk about the story behind ED 911. Who was your first patient? What got you thinking about a more interventional approach to erectile dysfunction?
Well, we like to call it ED 911 because we don't want to reference to 9/11. So, and we do have a website, ed911.com. So, look, I was minding my own business about 4 years ago, and an unfiltered patient came in my office named Mark, and we used a lot of analogies. Venous disease in the legs is pretty simple. It's leak in the attic, flood in the basement. Veins leak, and they cause you, lower extremity problems. And so he said, "Well, gee, does this leak in my legs have anything to do with the venous leak in my penis?" And number one, I was then, and I still am embarrassed to say, as a vascular expert, I'm a vascular surgeon. I just don't use blades. I had never heard of this, Elliot. I'm like, venous leak in a penis. It's like, we all know if arterial flow doesn't get into the penis, it's not working, but I'd never heard of this. But the second thought I had after being embarrassed for not knowing that it existed was, I can fix this. And I literally said that to the patient. And he is my first patient, and he's a dear friend, and we've helped him a lot, but I didn't even know it existed. And then, I've since realized, look, if you're a guy, you're not talking about a broken penis to anybody, maybe not even your urologist. And now that I'm a chief resident in urology over these last several years, um, I think half the people I see never even see a urologist. They're off, you know, doing other, non-FDA approved things, because they're desperate for care. But I won't go off into that. The moment he said that, I said, I can fix that. So I bring together, my vast experience, honestly, in interventional radiology and being, quite expert at venous and lymphatic medicine. And I knew we could fix it, and we've treated dozens of patients now over the last 2.5 years, and the results are simply astounding. I did not. This patient said, "Hey, I'm willing to do this," and if it weren't for this patient, we would not be here today. He had literally signed a consent form for a penile implant. I think I can say this. I'm working very closely with the chairman of urology at the University of South Florida. He's an internationally renowned andrologist named Dr. Raphael Carrion. And he literally signed an implant consent, and he was on a maximal dose of ICI, somewhere around 90 units. And for those who are familiar with it, if you get up over 100 units, it's dangerous, and they say it's time for implants. So
And
this guy
ICI
had
is
been
commonly called trimix or some. Go ahead.
trimix or bimix or
Right.
intracavernosal injections. And so he'd been happily doing this for probably a decade, but he was at the end of his rope. And after 2.5 years, we have him down to really an introductory dose of ICI. And he and his wife couldn't be happier. So we made a big difference for him and a lot of other patients where pills don't work, ICI doesn't work, but that's how it got started. And I
Well,
said,
just
look, Mark, that's
yeah.
how it
I
got
mean,
started.
the pills put more blood in, and we doctors have been led to believe by urology leaders and by pharma to think, well, that's the answer, to put more blood in, put more blood in. But our research and what you're doing indicates strongly that the problem for many men is on the venous side of the circulation and can be fixed with a ring and your interventions. So what exactly is venous sclerotherapy in layman terms?
Well, I'm going to candidly say that our procedure is patent pending. We're going to be filing in the next few weeks for a utility patent, so I'm not at liberty to go into a lot of details. However, I it's you can go check me out on LinkedIn, but we're internationally renowned expert on what's called foam sclerotherapy, which is just a fantastic treatment that most of our listeners have never heard of, that's used all over the world. And again, I can only tell the truth all the time, and I'm going to. The reason you don't know about it is because billion-dollar companies don't get rich when Dr. Pittman or other physicians use foam sclerotherapy. So, what tends to be promoted is devices and procedures that make billion-dollar companies a lot of money. I'm not making a value judgment, I'm stating a fact. So, I'm one of the few luminary vein doctors in the world that promotes and talks about something that I don't get paid much to do. I'm not a saint, but I am dedicated to what's best for patients. I'm a 28-year cancer survivor. I faced death. I understand what it means to be a patient. And there's nothing better than foam sclerotherapy to take care of leg veins. And I didn't invent it, but we have perfected it. And so that is part of the treatment. It's essential to the treatment, but what we're doing has never been done in the world, or we wouldn't have been awarded a provisional patent on it. And we're having astounding results.
Yeah, and you call this the edge procedure, and you've published an abstract about this that is, that I noticed and got is frankly the reason why we're working together because the results are quite astounding. I mean, you have several patients who had not been able to achieve full erection before the procedure who were able to. What are you seeing long term? Are you seeing that this procedure has to be repeated? How long do you think the benefits last for?
That's a great question. Again, I'm going to ease into this. Lower extremity venous disease is a chronic progressive disease process. It's never one and done. There are people listening to me right now who've had venous treatment and their vein doc said, "Hey, we did a bunch of procedures and, we're all done now. Go have a nice life." That is completely wrong. Venous disease is like dentistry. You don't have to, you don't have to go to the dentist. You could just brush and floss your teeth forever, but at some point the tartar is going to build up and the cavities are going to come. So everything that I'm very familiar with in the legs is going to happen from my prediction and has been happening in the third leg, excuse me. So at this juncture, after dozens of patients, I've told them this is a clinical outcome. Either your penis works or it doesn't. And thank God, virtually every one of them's improved. Okay. Have we made them all teenagers? No. But I'm packing the cannon a little here, Elliot. We're early on in this experience, right? I don't want to hurt anybody, and we haven't done that yet. So, um, my first patient, for instance, after, I don't know, almost a year, I went back and I did a little tune-up, and he's doing better than he ever has. So, think of dentistry. Patients are likely to need small tune-up procedures a year, 2 years, 3 years later. This is exactly the same way that we handle patients with lower extremity venous disease. And it's just like when we dilate an artery or stent an artery. We don't discard the patient. We don't say, "Hey, go have a nice life." We surveil them, they come back, and at some point they may or may not need a redilatation or something like that. So, do I predict this is a one and done procedure? Absolutely not. It's not. Just like it wouldn't be in your lower extremities or your legs. But the tune-ups, first of all, the procedure's a drive-by and the tune-ups are a drive-by.
So, Steve, excuse me, Chris, thus far, about how many men have had this procedure, and what have been the safety outcomes?
We're pushing about 50 treatments, and I've had no complications. What I knew we wouldn't have much intraprocedural pain because we're just good at what we do. So we had nobody hit me, cuss, leave, not come back, or even flinch when I do these. What I did not predict is typically after we do leg veins, people get mildly tender, but I have not had a phone call from a patient. They all get my phone number. So the post-procedure discomfort is minimal to nil. And I'm sorry, you asked me one more thing.
Um, uh, I don't recall. I think you answered the question. Um, what basically your point is that thus far that this has been safe
Oh, safety,
and
safety. So we have had zero
right,
complications. And so, I met with my team earlier today. We are going to put all of our statistics, the actual IIEF increases, the erectile hardness score increases on our website. My director of marketing is about 3 feet away, and we're going to have a live tally very soon at the ed911.com website with our improvements. We're that confident
great.
about what we're doing. And I want everybody to understand, this is Lewis and Clark stuff. First thing I don't want to do, first doctor, do no harm. So we're always slow and deliberative, but for the first year, year and a half, I'm doing Lewis and Clark stuff that had never been done before. We're much more comfortable with what we're doing. We are getting results
Chris,
much.
Lewis and Clark had to worry about being attacked by Indians, worried about
That's
starving
right.
to death. I don't think
That's
that's a
right.
great analogy for what you're
That,
doing.
that's
I think,
where, well, you live along that trail somewhere in
yeah,
Montana,
I don't think that's a great analogy for something that you've
but
done 55 times
well,
with absolute
at
safety.
this
So,
point, at this point, so I'll advance to football. Today, I'm getting better results quicker than we did when we started. That's the point I'm
excellent.
trying to
And
make.
you're an innovator of what is a very promising, fresh approach to a very exasperating problem. So your future plans then are one, you're obviously going to keep on doing this procedure in your clinic. What are your plans to spread this beyond your clinic, to train other doctors? And what's been the reaction of other doctors to about learning or incorporating this procedure into their approach to erectile dysfunction?
Okay, lot of answers there. Obviously, a lot of my vein colleagues are extremely interested in learning this procedure. I talked about a patent. I could be dead by the time, we do anything with a patent. So that I'm going to put that on the side. There are so many guys that are suffering out there without any help. We're direct to market. We're direct to market now. We got a lot of patients to help. We don't need a patent. So my goal is, yeah, I'll train some venous doctors to do this, but I think the ultimate goal is to train urologists to do this.
Good,
They're the
excellent.
ones seeing the patients. They don't have any option to help these folks short of a penile implant. So my
Yeah,
dream, and I can do it, is to train urologists to do this
I mean,
procedure.
speaking of penile implants, and we've had three men who have used our tech ring to assess their nocturnal erections. Three men who were told that they need to get an implant, decided not to get an implant because
Yeah,
they had nocturnal erections, and
yeah,
there's no way for them to know that without our
yeah.
technology. How do you see our technology being used in your practice?
So I love just telling a story. So, I saw I'm not doing a CME, so I can talk about anything I want. I go to the MenMD site, I see this firm tech company, and I say, oh, this looks interesting. I think I'll try the Fitbit for the penis, which, excuse me, Elliot, that's what I call his device. And I eat all my own dog food here, so I tried it out. Fortunately, I don't need my own procedure, but I may one day, Elliot, so I need to train some other people pretty quickly. But look, I tried it out. I thought it was interesting. And look, we're known for award-winning research here, so I'm not going to do hype stuff. So there's three things we're doing at ED 911. Number one, we do patient-reported outcome inventories on every patient, every visit. These are internationally vetted inventory. So it's not, I don't think they're doing better. The patient thinks they're doing better. So that's part of the research. The second is the penile duplex. To fill in the gaps from earlier question, we're doing duplexes before and after treatment. Follow me? I don't think anyone's doing that. So that's the second piece of the research where firm tech comes in a major way. And I reached out to Elliot, I think last October, and we become fast friends. Is I see this Fitbit or the firm tech that measures nocturnal tumescent frequency, duration, and firmness as a um, as a way to measure erectile health without any outside influence, like psychogenic influences. So where we've implemented it in our protocol is I want my patients that want treatment to use the FirmTech device overnight for at least 6 days to get a baseline of their frequency of nocturnal erections and the health of erectile health. And all those results are in a very cool way, in a HIPAA compliant way, put in a platform where I can review those results. So we want our candidate patients to use it on the front end. And then after my treatments, I want them to use it. So this is just one more piece of robust information that's not subject to psychogenic influences, partner influences, and that kind of stuff
Mhm.
to prove that what we're doing is helping patients. I hope that makes sense.
Yeah, well, Chris, we're very excited about what you're doing because men who have significant venous leak, frankly, they have no other alternative right now other than some unsuccessful surgeries
Yeah.
approaches that, like in Thailand. Uh, but at this point, we're reaching the end of our time. I'd like to open up for questions and answers for the next 4 or 5 minutes. Is there anyone here who wants to raise their hand and ask Chris or myself a question?
Come on, we got any brave people want to talk about ED? Come on. I'm feeling good all under. Who remembers the elevator commercial for Haynes? Got to get rid of the stigma, folks.
Okay. Well, if no one wants to ask the question, oh, someone. Okay, go ahead, Riley. Let him in.
Hey, good morning. Can you hear me?
Yes.
Yes.
A, a wonderful technology on both sides of the house. I'm a user of Firm Tech myself, which delayed my potential thought of doing an implant. Do you know if this procedure will be covered by insurance or is this going to be out of pocket for
It,
a patient?
it is 100% absolutely not covered by insurance.
Okay.
It's
Thank
cash. And yeah, and I don't find it being covered by insurance probably 5 or 10 years. That's how long it
Yeah.
takes to get an
Uh,
FDA approved product to market. So that's why we're going direct to market. I'm not waiting for a patent and FDA approval. That is a long process, ladies and gentlemen. So yeah,
yeah.
it's
I call
cash
managed
only.
care and Medicare the don't cares.
Yeah, yeah.
A follow-up question. Can you do out-of-state patients?
Yes, we have people fly in from all over the world for what we do here, not just at ED 911, but Vein 911, and we can absolutely help patients. I can treat them twice in a 24-hour period. So if you fly in, stay overnight, I can see you again the next morning. But we absolutely have a program for out of the state and out of country people, not a problem. There's some chat questions. Where are we located? We are in Tampa, Florida. It's a terrible place, especially this time of year. Yeah, we're in Tampa Bay, Florida. How soon before others can offer this? I think that's going to be a while. Okay, it's still considered an experimental procedure. So I don't think it's going to be coming to a clinic near you in the next couple of years. Um, and the cost is you can ask us at ED 911 offline. But if I had a broken penis, I would mortgage my house, but that's me. I think there's some other stuff. The name of the procedure, we just got did we get a registration for it? It's called EDGE procedure, erectile dysfunction, gentleman's enhancement procedure, or just EDGE procedure. But if you go to ed911.com, you can figure all that out. There's a chat here. I had prostate surgery. They saved one of the two nerves with pills and pumps and rings. I can get erection for like 5 seconds, but the blood seems to leak out almost immediately. Yes, I would say, you know, I just said earlier, history is more important than an ultrasound exam. So if somebody can achieve an erection but not maintain it, that's venous leak all day long. If you can achieve an erection, you're obviously getting blood flow. So I would say to this person that yes, it's worth an evaluation here. Um, and then I'm having trouble navigating this chat. But anyways, type 2 diabetes, yes, it can work. And for those who have arterial insufficiency, honestly, we're helping those patients too. If you don't have enough blood in, but you keep enough blood from coming out, you can get improvements. And candidly, we're getting good improvements. We are focused on venous leak, don't get me wrong, but we know theoretically and actually that we can and are actually helping people with arterial leak. Again, nothing's guaranteed in medicine, but at this juncture, we've helped everybody, but not everybody becomes a teenage guy again. How does this compare to low intensity shock wave? Well, we're actually treating the problem. Look, shockwave, I mean, come on. That's BS. I'm a vascular expert. You're not going to break up a bunch of plaque in there. We don't have time to get into that. But if the shockwave companies sincerely wanted to prove that what they do and what people pay money to do worked, they would do the kind of research I'm doing. They would, and I think there's only a handful of studies. Look, I'm a policy person. They're going to try to make as much money as they can for as long as possible, and then 10 years from now figure out, hey, this really doesn't work, and then they'll be on to the next thing. So that's what I think about PRP, platelet-rich plasma, and all these other things that don't have robust research behind them. I'm going to show publicly I'll just tell you right now, the increase in the IIEF score, which is 1 to 30, okay, 1 to 10 severe, 11 to 20 is moderate, 21 to 30 is mild ED. We are getting a 13 plus point increase in the IIEF. In the urological literature, what is significant for a urologist is greater than or equal to a 4 point increase. We are more than tripling that in our patients. There's something called an erectile hardness score. Okay. Three's three's good, you can achieve penetration. We are getting nearly 1.5 increase in that EHS score. So if you have an EHS of 0, 1, or 2, we statistically will get you to a 3 or a 4. I've had patients go from a 1 to a 4 in one single treatment. Ballpark cost is it's going to be high four figures, very high four figures. Phone of the clinic, I'd just go to ed911.com. Recovery time, there's no science here, but I tell people, hey, no activity for 3 days. After that, it's open season for intimacy. TURP
Chris,
procedure doesn't affect any of that. There's no age limit, and it looks like
Dr.
Elliot's going to
Pittman,
shut me down.
Dr. Pittman, I have a question. So the process, how does it work? How do people get to you or get to your clinic or what do they do?
I just go to ed911.com, our location, or
Chris, let me interrupt you. Just please put in the chat the
okay,
phone number of your clinic and the website so people have that information.
yep, got it. It's just simpler to go there. We have an assessment that we have people take there, but like I said, there's no, hey, we can't help you. I mean, I can give you statistical, our likelihood of helping you, but we're helping a lot of people. I'll leave it at that. There's something about a pelvic floor physical therapy clinic. Chris has a question about pelvic floor physical therapy. Um, if ED medications work, is one still a candidate? Um, you're a candidate for the procedure if the pills aren't working, or a fair number of guys have um, complications or bad reactions from Viagra and Cialis. But look, if pills are working for you, I don't think, in medicine, you don't want to do something if something less invasive is working. So I would say pills are working. I don't think you're a candidate yet. If they're not working or you can't take them, I would say we can absolutely likely help you. Penile enhancement injections. That is a great question, Bernie, because unfortunately, I've had two patients come with the girth procedures and they're putting hydroxyapatite, which is calcium. And the unfortunate truth is I can't see anything inside the penis. And if I can't with ultrasound see into the penis, I can't offer these guys treatment. And now I've talked to the girth enhancement gurus who do this, and all I need is a window, probably about a centimeter or a half inch, to see into the penis with an ultrasound. And I've been told by these girth gurus that they can inject something that can get rid of it and get me a window. Um, so, but I've had two patients with that, and unfortunately, and their history was compatible with venous leak. I can't see what I'm doing. Does it mean there's not other options? I think there are other options for these patients by an interventional radiologist using fluoroscopic guidance. So I could talk to people about that if we can't, achieve imaging of the penis. So I think there still are options for the girth folks.
Okay, let's at this point we've gone over. Chris, appreciate the work that you're doing. I think I wouldn't compare you to Lewis and Clark, but I think I compare you more to a profound medical innovator, and appreciate that. Everyone, this webinar is going to be publicized, so if you want to listen to it again or you want to pass it on to someone else, you'll be able to do that. And I want to thank everyone for attending. Thank you so much.
Thank you, Elliot. Have a good afternoon.